Ladies and gentlemen, we now move ahead to the last academic segment before lunch, and that will be a keynote address for the next 13 minutes, followed by 2 minutes of chairperson's observations on intensive statin therapy. And our invited speaker is Professor Enas from Illinois, United States of America. And before the address is delivered by Professor Enas, may I invite the chairpersons, Dr. A.K. Pancholia. He'll be joined by Professors Arup Das Biswas, Harshvardhan and Asha Murthy. And since this is a keynote address, we'll not be having any questions, and delegates can straight away head for lunch after this keynote address. Thank you very much.
I think, ladies and gentlemen, we all know that Enas is a huge, big name in lipidology and a lot of contribution in the whole globe. I'll hand over the mic to Chairperson Dr. Arup Das Biswas, Dr. Harshvardhan, and Dr. Pancholia to give the initial comments. Arup?
We have got little time left for the lunch, so I should be brief. Dyslipidemia is a very well-known risk factor for all kinds of prevention, and this forum for preventive cardiology is very apt topic, and we have got none other than Enas and Enas, who is the doyen in this field. Let's hear from him.
I think the therapy for hyperlipidemia has evolved over the years, initially using only small doses of statins to bring the lipid levels to just normal. Now we have reached a stage when we are talking of intensive statin therapy to reduce the lipid levels to as low as possible. To reduce the prevalence of coronary artery disease, it has been proved very useful. And I'm sure we'll hear a very good data on this from Professor Enas, who is an authority on this subject.
Enas, sir.
Thank you very much for giving me this opportunity, especially to Dr. Chopra and Naveen. And I really enjoyed the meeting, and also want to congratulate for allocating sufficient time for prevention, especially this topic on intensive statin therapy. We just heard about the prediction of what JNC 8 is going to be. This slide shows the state of affairs of blood pressure before the JNC 1. FDR, the President of the United States, had a blood pressure of 260 over 150 with heart failure, with renal failure, and was on digitalis and massage therapy and died from cerebral hemorrhage, because that was the state of the art of the treatment. Because BMJ in 1931 said, the greatest danger to a man with blood pressure lies in its discovery, because then some fool is certain to try and reduce it. JNC 7 defined optimum blood pressure as 115 over 75. Many of us may not be aware of the fact that there was a sea change in the understanding and cut points of cholesterol. Until 1985, the cut point for high blood cholesterol was 330, and in 2004, it was the optimum LDL-C was reduced to 40. The optimum LDL-C was set at 40 milligram. The risk of CAD increase is 30% for every 30 milligram increase in the LDL-C. Numerous studies by Pfizer on atorvastatin. As a matter of fact, 35,000 people have been studied with varying levels of cholesterol and established the safety and efficacy and outcome benefit in people with heart disease. How about people without heart disease? Statins have now become the foundation of preventive cardiology, both in primary and secondary prevention. It is no longer a cholesterol-lowering agent. It is the only agent that can affect the natural history of heart disease, coronary artery disease, and also produce regression. Yet, many of our doctor friends, as well as their patients, are not taking it. Why should our smart doctors deny a statin for themselves and their patients until after a cardiac catastrophe, although they will be jumping to use the highest dose of atorvastatin or rosuvastatin and lower the LDL-C the morning after a heart attack? Something to think about tomorrow. In the primary prevention, Jupiter trial has shown reduction in clinical events in 19 months. Nearly 18,000 people with LDL only 108 and not much of a risk factors. 44% reduction in the primary endpoint, which included MI, death, angioplasty, revascularization, and stroke. When the LDL-C was brought down or came down to 55, there was 70% reduction. So there were correction. When it was brought down to less than 70, there was 55% reduction. And there was 65% reduction in those who achieved LDL-C or less than 50, which means lower the LDL, the better it is. This slide shows those who achieved LDL-C less than 50 had a 65% reduction. In this study, 23% of the people had LDL less than 40, with no adverse effects. These and other studies led to the current definition of optimum LDL-C at the 40, and every 1 milligram increase in the LDL-C increased the risk by 1%. Also, this slide shows that if you treat, lower the LDL-C, the benefit depends upon not the statin use, but how much LDL-C reduction you achieve. You achieve 40 milligram, you get 20%. You lower LDL-C by 160 mg/dl, you reduce the risk by 80%. Also, if you treat 1,000 people, in secondary prevention you prevent 192 events and half that in primary prevention. There is also now data just published in the JAC that those who achieved LDL-C, those who had LDL-C less than 70 in Korea, those who were given statins had an additional 55% reduction in the need for revascularization and cardiac death by 53%. This may be extremely important for India, where revascularization is very expensive, whereas statins are not that expensive. Now, yesterday there was some discussion about the regression. Regression of the coronary atherosclerosis is achievable, doable, but we have to achieve and maintain an LDL of less than 70 and non-HDL cholesterol of less than 100 and a blood pressure of 120 and maintain it for at least 5 years. But it's not needed. But we can actually prevent the events without achieving the regression. When we talk about intensive statin therapy, we mean a reduction of LDL-C by at least 50%. The rosuvastatin is by far the most powerful agent. At the highest dose of 40 milligram, it can reduce the LDL-C by 62%, and at the second highest dose of 20, 55%. You need 80 milligram rosuvastatin to do this. So far we heard about the increased rates of heart disease. The focus is shifting to increase risk of heart disease. This is a data from the UK where heart disease among Indians is a hot topic. Not because they love Indians, because the National Health Service is going broke, doing angioplasty stent and bypass surgeries. The reason is shown here. The data from an ongoing prospective study with the white other referent, when they adjusted for the age, cholesterol, blood pressure, HDL, diabetes, insulin resistance, and even socioeconomic status. Indians have double the risk of developing and dying from heart disease in a country which has universal access to advanced medical care. Probably the reason for this underestimation is a genetic risk factor called lipoprotein a, which can double the risk on the top of Framingham risk factors as well as Framingham risk score. It is actually a shame that we always talk about JNC, European guidelines and American guidelines. We need our own guidelines by the Indians, for the Indians. And in the absence of that, I had the opportunity to chair the Indo-US Health Summit. Many of the distinguished people, some in the dais and some in the audience, was in the committee. And this is perhaps the most important slide of my presentation. The entire report, as well as the topic intensive statin therapy, can be downloaded free from my website cadiresearch.org, including this slide. See, we have recommended that in virtue of the highest risk of heart disease, Indians LDL-C should be less than 30 milligram, lower than recommended for the NCP guidelines. As a result, people with heart disease, chronic kidney disease, stroke, diabetes, metabolic syndrome, or elevated lipoprotein little a, the LDL-C should be less than 70. Since we have a big problem with the triglyceride, non-HDL cholesterol may be a better target. It should be less than 100. All others, the LDL should be less than 100, and non-HDL should be less than 100. The lipoprotein little a should be less than 20. Now, the important thing is that when you look at these numbers, the CAD is about 6 to 12%, CKD 10 to 15%, diabetes 10 to 20%, metabolic syndrome 35 to 50%, elevated lipoprotein little a 35 to 40%. So altogether, about 60 to 90% Indians will be high-risk individuals requiring LDL-C target of less than 70. Now let's look at the absolute benefit and risk of the statin. There is always this issue about the side effect versus the benefit. If we decrease the LDL-C by 80 milligram in secondary prevention and you treat 1 million people, you prevent 19,200 MI or death. But if you are using not intensive statin therapy, lower LDL-C by only 40 milligram, benefit is half, 9,600. In primary prevention, it's exactly the half of secondary prevention. But on the downside, we get only 109 myopathy, 30 non-fatal rhabdomyolysis, only 3 deaths from rhabdomyolysis. Peripheral neuropathy, 120. The new data shows that people can develop diabetes, almost 980. But no amount or physical or emotional stress will produce a miscarriage in a non-pregnant woman. Likewise, the statin produces diabetes only in pre-diabetic people. That is, people who are elderly, those who have high blood sugar or metabolic syndrome. The statins have now become, or fast becoming, the drug of choice in primary prevention, and the aspirin is dead or will be soon dead. The reason for that is shown here. If you give 1 million people aspirin, you prevent only 1,300 MI or death, 1,300. Whereas you produce 14,800 bleedings, 2,300 of which will be major bleeding requiring hospitalization, transfusion, or including stroke. In other words, for every MI you prevented, you produce 11 GI bleeding and 2 major GI bleeding. So how safe is intensive statin therapy? 100 times safer than diabetic medications, or 10 times safer than low-dose aspirin. So to summarize, the optimum LDL-C is currently standardized at 40 mg/dl. For Indians, the LDL-C target is 30 milligram lower, that is 70 milligram for those with the CVD, diabetes, metabolic syndrome, elevated LPL or chronic kidney disease, and less than 100 for all others. Intensive statin therapy is often required. If you cannot achieve this target, a 50% reduction in the LDL-C is reasonably satisfactory, but intensive statin therapy is better than moderate statin therapy. The absolute benefit from the statin increases over time, whereas angioplasty stent and bypass decreases over the time. So if you combine both, you can actually extend the life of the angioplasty stent. The treatment of statin should be lifelong, should not be stopped. Otherwise, life may not be long. The potency of the statin varies 8-fold, with the highest potency being rosuvastatin, which is almost 4 times more potent than atorvastatin. Serious side effects are rare. Even though there is a risk of diabetes, we can prospectively identify who are at risk, and still the benefit outweighs the risk. Broader and earlier use of potent statins in adequate doses to achieve and maintain an LDL-C target of less than 100 to 70 have a huge potential to reduce the CVD burden in India than all other interventions combined. Because although we have more than 300 risk factors, there is only one cause, that is the LDL, and the second one to be added will be lipoprotein little a. So let me stop with this, my own statement. Statins are poised to perform greater wonders in the 21st century Then antibiotics lead to infectious diseases, and H2 antagonists and PPIs lead to peptic ulcer in the 20th century. Thank you very much.
Thank you, Dr. Enas, for his wonderful and excellent, outstanding presentation, and with his immense contribution to the study of CAD in Asian Indians. And the message is very clear that statins has to be given for lifelong, and the doctor should not recommend statins when the patient develops cardiac catastrophe. It should be given prior to it. The message is very clear. And we should make our own Indian guidelines rather than following American guidelines and other guidelines, European guidelines. So he is very clear in his thing. He has been touring in India. He had a lecture in Tamil Nadu in Chennai last 2 days back, and we really enjoyed the talk. Thank you so much, sir.
Thank you, Aisha. I think I'll hand over the mic to Naveen. Let's see what comments.
Well, that was really an excellent, elegant and very excellent talk, Enas, as usual, always. It's really such a pleasure to hear you. One of the things you may not realize that Dr. Enas, and this going back to history, that he was one of the founders and leaders of the American Association of Physicians of Indian Origin. And if I remember, we worked together and made sure that that association did not become extinct, and is now, as you know, one of the most powerful organizations in the United States of America. Also, I think it was at that time during my presidency that both Enas and I decided we should embark on this coronary artery disease study, and I thought, and we all thought, that the best person to lead that study would be no one else but Enas, and I think it started right from there. About it was 89-90 when you first started this, 1990 when you started this study. That's great. Just to give a little bit historical background about Dr. Enas. My pleasure to do that.
Thank you, Naveen. Pancholia?
Well, it was a wonderful presentation by staff and clearly showed the importance of the lower the better, particularly in Asian Indians. So my question to you, should it be put in the drinking water of the nation?
No, I don't think so.
I think WHO recommends to add it in the water.
Then the cardiologist will have to drive taxi to make a living.
I think, ladies and gentlemen, Enas has given a very, very lucid presentation on statins. And there is no doubt that statin is first drug and the top drug to be used if you really want to reduce the burden of CVD and not by aspirin. Do you agree with me, sir? I think it's a very, very wonderful data and evidence-based data to support what I'm saying. And I think everybody should take relatively at a younger age. Would you like to give a comment? What is the youngest age you recommend, sir?
9, that's the latest recommendation. The United States has recommended that all children between the 9 and 11 years of age should be tested for the cholesterol. Sooner if they are obese or family history of heart disease, and again at 15 to 17 years of age. Also at age 10, medication should be started. From age 2 to 10, lifestyle modification, except in very rare case of high LP-Little or FH. And the target is 190 LDL without risk factors or 160 LDL with family history. For Indians should be less than 30 milligram lower, and treatment started and continued lifelong. 9 years.
So I think let's give a big hand to Enas for his most lucid and outstanding presentation of this particular topic.
Ladies and gentlemen, may I request our chairpersons to kindly step forward and present the medallion and the citation to Professor Enas. Thank you, chairpersons and Professor Enas for delivering the lecture. Ladies and gentlemen, we are still running about 4 minutes ahead of time. The scheduled closure for the pre-lunch session was 1:18. We are 1:14.